Distal Tibia Pilon Fractures. A didactic video that includes the diagnosis, logic and treatment methods with surgical approach choices. Kamal Gokuz MD. Bashkent University Alanya Research and Practice Center. Acknowledgement. The majority of this video was created using a book source cited below. RMLTS. 2019, Manual of Fracture Management. In, Rameltes, ed., Georg Team Verlag. 1 SD ed. Team, Stuttgart. Pages 16 to 25. We would like to thank the authors listed below for their exceptional work. Stefan Ramelt, Michael Swords, Mandeep Estilon, Andrew K. Sands. Pilon fractures are rare, accounting for less than 10% of fractures around the ankle. The soft tissue in the distal tibia is unforgiving with poor soft tissue coverage, increasing the difficulty of fracture management. Pilon fractures are known for comminution, displacement of the articular surface, and soft tissue injury. Most fractures will require operative fixation due to alteration in joint congruency and overall limb alignment. Definitive operative treatment should be catered to the specific fracture pattern, soft tissue injury, and patient. Appropriate timing of surgical treatment is essential for successful outcomes. Anatomy and pathomechanics. The distal tibia is a relatively subcutaneous bone. Soft tissue coverage at the ankle level is minimal, consisting almost entirely of skin and tendon. As a result, injuries in this area must be managed carefully. Open injuries require emergent management, and may require free tissue transfer depending on severity. Due to the subcutaneous nature of the ankle, grossly displaced fragments may lead to soft tissue necrosis if left displaced. Anatomy and pathomechanics. The medial border of the tibia flares out and terminates in the medial malleolus with the deltoid attachment. The anterolateral surface has the tubercle of Chapit, and the attachment of the anterior inferior tibiofibular ligament. The posterior portion of the tibia is the attachment site of the posterior tibiofibular ligament. Laterally the tibia has the incisura fibularis, and the interosseous ligament and membrane. Screws directed from medial to lateral must be measured accurately as the AP X-ray may not accurately reflect screw length. Anatomy and pathomechanics. The extensor tendons of the foot and ankle are contained in the anterior compartment along with the anterior tibial artery, and the deep peroneal nerve. Anteriorly displaced fragments may compromise perfusion of the dorsum of the foot by occluding the anterior tibial artery, Fig. The lateral compartment contains the peroneus brevis, and longus muscles. The superficial peroneal nerve is vulnerable, as it crosses the fibula and moves anterior over the distal tibia and ankle. It must be identified and protected with anterior and anterolateral approaches. The deep posterior compartment contains the flexor hallucis longus, FHL, which originates on the fibula and crosses the posterior ankle to run on the medial side of the foot. The muscle belly and tendon of the FHL must be identified and retracted with posterior approaches. The tibial nerve and the posterior tibial artery are also in the deep posterior compartment between the FHL, the flexor digitorum longus, FDL, and posterior tibialis tendons. The posterior tibial tendon may become entrapped with displaced fractures that exit along the posteromedial border of the tibia, blocking reduction. The Achilles tendon, Cage's fat pad, the gastrocnemius and soleus muscles are in the posterior compartment. The Achilles sheath, peritendinium, is left undisturbed in posterior approaches. The psoral nerve transitions from midline at the mid-level of the tibia to posterolateral at the level of the ankle. Fractures are typically the result of an axial load. Roughly 60 to 70% will have an associated fibular fracture. The dome of the talus impacts on the articular surface of the tibia resulting in a fracture. Often, a bending component occurs, secondarily resulting in failure in tension on one side of the tibia, and failure in compression on the other. The amount of comminution and displacement of fracture fragments is directly related to the amount of energy. The fracture pattern seen at the articular level consists of three main fragments: a medial fragment, an anterior or anterolateral fragment, and a posterior fragment, figure. Comminution generally occurs where the fracture lines meet. Each of the three major fragments may be comminuted, and have additional fracture lines. Preservation of the vascular supply is important. The soft tissues should be handled with care and retracted only as necessary to avoid wound healing problems. Excessive stripping of fragments should be avoided to prevent devascularizing fracture segments. Fractures of the distal end segment of the tibia in the AU/OTA fracture and dislocation classification system are assigned the number 43, which is applicable for pilon fractures. The classification divides the fractures into three types. 43A fractures include extra-articular fractures. 43B fractures include partial articular fractures of the distal end segment of the tibia. 43C fractures are complete articular fractures. Each fracture type can be further classified into groups and subgroups to better describe and code the particular injury. Qualifications are also included in the classification at certain levels to further describe fracture line locations with more precision. See the appendix for information on the AU/OTA classification of distal tibial pilon fractures. Clinical assessment. The initial evaluation of pilon fractures should be thorough. Examination of sensation should include assessment of the sensory nerve distribution. The deep peroneal, superficial peroneal, sural, and tibial nerve distributions including the medial and lateral plantar nerves, should all be evaluated and recorded. Perfusion should be assessed by palpation of the posterior tibial and dorsalis pedis pulses. Capillary refill should be assessed. Clinical assessment. Surgical treatment is typically performed between 5 and 21 days after injury, depending on the severity of the soft tissue component of the injury. Imaging. Initial imaging for pilon fractures includes lateral, AP, and mortise ankle views. Full-length X-rays of the tibia are necessary in fractures that extend proximally. X-rays obtained when the overall limb alignment is improved, such as after reduction, are of more benefit in evaluation of the injury. Intra-articular fractures are best examined with a computed tomographic (CT) scan including sagittal, axial, and coronal planes. This will allow full assessment of the fracture pattern, and aid in surgical planning. The necessary surgical approaches as well as fixation construct will be planned from the CT scan. Additional foot X-rays may be needed based on the individual injury being evaluated. Non-operative treatment is rare for pilon fractures and is reserved for fracture patterns with minimal displacement and in patients with comorbidities that put them at increased risk during operative treatment. Extra-articular fractures with minimal alteration of the overall alignment of the tibia may also be treated without surgery by cast immobilization. A splint is used until such time as the injury-related swelling has resolved, allowing a cast to be applied. Gross alteration of the alignment of the tibia or articular surface may cause problems with limb alignment or stability. Serial X-rays are necessary to ensure articular congruency and limb alignment are maintained over time. Operative treatment. Emergent operative treatment is indicated for open fractures, fractures with an associated dislocation, and fractures with soft tissues at risk of breakdown due to gross fracture fragment, displacement or malalignment. Current or impending compartment syndrome is also an indication for emergent operative treatment for compartmental releases. External fixation. Most pilon injuries will be treated with temporizing external fixation at the time of injury to restore limb alignment and length, providing relative stability, while the soft tissue injury recovers, Fig. This method of staged management results in lower rates of soft tissue complications with delayed definitive fixation. The goal of external fixation is to center the talus under the tibia on both AP and lateral X-ray views. Distraction will prevent further injury to the articular cartilage of the talar dome, which may occur from the opposing fractured surface of the tibia. Operative treatment. Fixation of the fibula can be performed at the same time as external fixation application or on a delayed basis. Ideally, the individual who will ultimately manage the pilon fracture should also treat the fibular fracture. Poor incision placement and inadequate reduction may complicate care. Appropriate timing of surgical fixation is necessary. Surgical treatment will allow anatomical restoration of the articular injury. This requires direct reduction by open approaches. In general, the external fixator is maintained on the limb until after final fixation has been achieved. The external fixator maintains overall limb alignment while reduction of the articular surface is performed. Patient positioning. The majority of pilon fractures are treated in the supine position. Select fractures may require additional posterior approaches. Posterior fractures that are partial articular injuries must be treated with posterior approaches. Patient positioning. The patient is positioned using a beanbag in a supine position on an operating table that is radiolucent distally. The patient is positioned with the feet at the end of the table, allowing the surgeon to move easily around the end of the table as needed to work through any combination of approaches that are necessary. A foam positioning ramp is placed under the affected leg. Alternatively, pillows or blankets can be used to elevate the affected limb to avoid interference with C-arm imaging. A bump or wedge is placed under the ipsilateral hip to internally rotate the affected leg so it is positioned perpendicular to the floor. A tourniquet is placed on the upper thigh and a non-sterile U-drape placed circumferentially just distal to the tourniquet. Patient positioning. The patient is placed prone after the airway is secured. Chest rolls are placed under the patient. A small pillow under the lower leg elevates the affected extremity, easing instrumentation and imaging. A bump is placed under the contralateral hip to internally rotate the affected leg so it is positioned perpendicular to the floor. This allows improved ability to obtain C-arm imaging. When imaging the ankle, the C-arm will typically need to be tilted chordad to improve imaging. The leg must be internally rotated to get a mortise view. The C-arm is positioned at the side of the table and opposite the injured extremity. The monitor is placed at the head of the table within view of the surgeon. Occasionally, tilting the C-arm chordad or cephalad 20 degrees will aid in obtaining images of the anterior and posterior portions of the articular surface by accommodating for the curvature of the distal tibial articular surface. Surgical approaches. Numerous surgical approaches can be used for fixation of pilon fractures. Generally, open surgical approaches are required to directly reduce the articular surface with plates and screws used to maintain the reduction. Most type C pilon fractures will require more than one incision and more than one plate. Historically, it was recommended that incisions be at least 7 cm apart. While this is not the case today, it is still imperative that excessive dissection and undermining of skin flaps should be avoided, as it will increase the risk of wound complications. The single most important factor in avoiding soft tissue complications related to surgical treatment is appropriately timing the surgical intervention when swelling has resolved. Alternative approaches for operative management include management with ring external fixation for limb alignment, percutaneous screws for articular reduction, and percutaneous screws coupled with intramedullary, nailing. Anterolateral approach. Skin incision. This incision is centered at the ankle joint, parallel to the fourth metatarsal distally, and parallel to and between the tibia and fibula proximally. Dissection through the skin and subcutaneous tissues should proceed sharply with the maintenance of full thickness skin flaps. Since the anterior compartment muscles arise from the anterior fibula, the incision is usually not extended more than 7 cm above the ankle joint. Distally, the incision can extend as far as the talonavicular joint. Take care not to damage the superficial peroneal nerve which lies directly beneath the skin. This nerve invariably crosses the surgical incision proximal to the ankle joint. It should be identified, mobilized, and protected throughout the surgical procedure. The fascia over the anterior compartment of the distal tibia is incised sharply, beneath the superficial peroneal nerve. Distally, the extensor retinaculum is incised, and the anterior compartment tendons are all retracted medially. Proximally, the entire anterior compartment musculature, including the peroneus tertius, can then be mobilized and retracted medially. These muscles and tendons are usually easy to mobilize from the underlying anterior tibiofibular ligament, the periosteum of the distal tibia, and the joint capsule. Application of a distractor intraoperatively greatly assists with articular visualization. Additionally, the distractor helps to align several of the major articular fragments. A 4 mm Schanz pin is placed transversely from lateral to medial at the talar neck through the surgical incision. A second 4 mm Schanz pin is placed from lateral to medial at the tibia, proximal to the anticipated plate application. The pin placement in the talar neck, which is anterior to the axis of rotation of the talus, will produce ankle joint distraction and plantar flexion, maximizing articular visualization. The threaded rod of the small distractor is placed posterolaterally to avoid interference with reduction and implant placement. This approach is useful for the management of complete articular injuries, partial articular injuries of the anterior or anterolateral articular surfaces, and for submuscular plating of the tibia. The surgical approach extends over the ankle in line with the fourth metatarsal. The superficial peroneal nerve is at risk and requires identification in the proximal extent of the incision, figure. The approach results in medial retraction of all of the tendons of the anterior compartment, including the peroneus tertius if present. The incision may be extended distally to address concomitant foot injuries. Proximal extension of the approach is limited by the contents of the anterior compartment. Anterolateral approach. This approach allows direct access to the chapit tubercle and central comminution. In most situations, direct articular reduction and distal plate fixation will occur through this incision. The plate will be slid under the anterior compartment and proximal screws will be inserted through a small secondary incision or by percutaneous methods. Fixation of the medial portion of the injury is limited with this approach, and a second approach to address the medial injury is often necessary in more severe injuries. Anterior approach. The anterior approach uses the interval between the anterior tibialis and extensor hallucis longus. The dorsalis pedis artery and the deep peroneal nerve are located laterally and over-retraction should be avoided. The neurovascular bundle is at risk both proximally and distally in this approach. The entire anterior portion of the distal tibia is accessible using this approach. Anteromedial approach. The anteromedial approach can be used for fractures with significant displacement and multiple intra-articular fracture lines involving the central and/or medial portion of the distal tibia, including the medial malleolus. The skin incision is made just lateral to the tibial crest and then dissection continues just medial to the anterior tibialis tendon. The sheath of the anterior tibialis tendon is maintained throughout the dissection. The anterior aspect of the distal tibia can be approached between the posterior border of the tendon sheath and the periosteum. Care must be taken to avoid over-dissection, particularly when a complementary small anterolateral incision is made to address the chapit component. Surgery should be performed on a delayed basis when soft tissue swelling has resolved. Careful handling and closure techniques for soft tissues are necessary to reduce the risk of wound healing complications. Soft tissue flaps should be full thickness. Skin incision. The incision for the anteromedial approach starts about 5 to 8 cm proximal to the ankle joint, just lateral to the palpable tibial crest. It runs in a straight line over the ankle joint towards the base of the navicular, following the medial border of the anterior tibial tendon. A straight incision provides a better approach to the anterior part of the tibia than a curved incision. The dissection is deepened through the periosteum, just medial to the anterior tibial tendon. It is critical to leave the tendon sheath intact and to immediately repair any traumatic or inadvertent disruption that exposes the tendon directly. A medial plate can be slid in a myofascion. Minimal exposure and careful handling of the periosteum are essential to prevent any further vascular damage of the fracture fragments. Lateral dissection between the posterior border of the tendon sheath and the periosteum is performed to get access to reduce the anterolateral fragment. However, for fixation, screw insertion, it might be necessary to have a separate small anterolateral incision. The tibial joint is opened in the sagittal direction, usually in line with the fracture line between the two main anterior articular fragments. Any transverse incision of the anterior capsule to further expose the joint should be kept short, as this risks devascularization of the anterior fragments, supplied by branches of the anterior tibial artery. A large distractor, from tibia to medial talus, pulls the talus distally, aiding exposure. A bone spreader can be used to separate the anteromedial and the anterolateral articular fragments. This exposes the joint, allowing an excellent approach to the center as well as to the posterior part of the fracture. Posteromedial approach. This surgical approach allows for direct reduction and visualization of posteromedial fracture fragments. Placement of an anti-glide plate to reduce the shaft component is easily performed with this interval. This incision is also useful in removing the posterior tibialis if it is entrapped in the fracture fragments. The incision is curved from just distal to the tip of the medial malleolus and follows along the posterior edge of the medial tibia, Fig. The deep dissection may be carried out in 3 different intervals depending on the specific needs of the case. Dissection may be carried out between the posterior border of the tibia and the posterior tibialis tendon. The tendon should be left in its sheath at the level of the medial malleolus or carefully repaired when closing. Alternatively, dissection may be carried between the posterior tibialis and the FDL. Finally, in select cases the interval between the flexor digitorum longus and flexor hallucis longus may be used. This interval is seldom used, as it requires direct exposure and protection of the neurovascular bundle. Posteromedial approach. Incision. The incision is centered at the ankle joint, between the Achilles tendon and the posteromedial border of the distal tibia. Proximally the incision is parallel to the posteromedial border of the tibia. Distally the incision is parallel to the path of the posterior tibial tendon. Posteromedial approach. The incision is deepened through the subcutaneous fat and fascia, and the deep fascia is revealed over the tendons of the tibialis posterior and flexor digitorum longus, the posterior tibial neurovascular bundle, and the flexor hallucis longus tendon. For access to the posteromedial quadrant of the distal tibia, it is necessary to carefully incise the deep fascia proximally, protecting the neurovascular bundle. Posteromedial approach. Deep dissection. The interval used for deep dissection is dependent on the location of the major fracture fragments. It may be located 1. Between the tibia and the posterior tibial tendon. This is only useful for proximal exposure, as the distal posterior tibial tendon should not be dissected from the posterior tibia. 2. Between the posterior tibial tendon and the flexor digitorum communis, see illustration. Deep dissection. 3. Between the flexor digitorum communis and the flexor hallucis longus. This interval requires direct exposure and protection of the neurovascular bundle along its length. The neurovascular bundle can be retracted anteromedially or posterolaterally. The posterolateral approach allows for direct reduction of the posterior portion of the articular surface. The incision uses the interval between the peroneal tendons and the Achilles superficially. If the fibula is also fractured, it can be approached with this incision as well. The sural nerve is protected in the subcutaneous tissue without direct dissection. The peroneal fascia is opened and the superior peroneal retinaculum is released, allowing the peroneals to be retracted medially to expose the fibula. To expose the posterior tibia, deep dissection is carried out medially to the peroneal tendons along the lateral aspect of the FHL muscle belly, with the muscle retracted medially, figure. The entire posterior aspect of the tibia is accessible. The sural nerve is at risk and is generally located above the superficial crural fascia and retracted laterally within the subcutaneous fat. Damage to the peroneal artery or veins may occur at the level of the ankle joint and must be identified. The posterolateral approach. This approach lends itself to fracture patterns that are primarily displaced fractures of the posterior tibia with little or no involvement of the anterior tibial surface. It has the advantage of allowing fixation of both the fibula and tibia through the same incision. It is also useful when the soft tissue injury prevents use of the anterolateral or anteromedial exposures. The patient is placed into a prone or lateral position. The posterolateral approach. It is important to be aware of the course of the sural nerve as it courses from the posterior midline of the calf proximally to just posterior to the fibula distally. The sural nerve is identified under the superficial fascia layer and it is usually included in the lateral flap. If the dissection is extended more proximally, it may be necessary to work on either side of this nerve. The posterolateral approach. Superficial surgical dissection to the fibula. If the fibula requires fixation, this option is chosen. Full thickness superficial flaps should be maintained to reduce the risk of skin necrosis. Superficial dissection should be taken down to the attachment of the peroneal fascia on the posterolateral border of the fibula. The fascia is incised, and the peroneal muscles are retracted medially. Exposure of the fibula is completed by releasing the posterior periosteum where the peroneal fascia inserts on the bone. The fibular fracture fragments can then be reduced, preserving their soft tissue attachments. The fibular reduction and fixation are usually completed before tibial exposure. Surgical dissection to the tibia. Access to the tibia is through a separate plane which is developed on the posteromedial border of the peroneal muscles. These are now retracted laterally. Exposure of the posterior aspect of the tibia is achieved by developing the interval between the peroneal tendons and muscles laterally and the flexor hallucis longus, FHL, medially. Deep surgical dissection to the tibia. Flexor hallucis longus, FHL, is recognizable from the very distal extent of its muscle belly. It can also be identified by moving the great toe. With sharp dissection of the FHL along its lateral border, the entire posterior aspect of the tibial surface can be exposed by retracting this muscle medially. This also provides protection of the posteromedial neurovascular bundle. Note, either the peroneal artery and vein, or a significant branch, can be injured in this part of the exposure. If a tourniquet is used, it is wise to deflate the tourniquet before closing this layer to ensure hemostasis has been achieved. Visualization of the articular surface or small fragments preventing reduction of the articular pieces can be difficult. The posterolateral fragment is rotated laterally around the usually intact posterior tibiofibular ligament. The interval between the bony fragments is developed, giving access to the center of the fracture. Postoperative care. The patient is instructed to elevate the extremity to prevent wound complications associated with postoperative swelling. Sutures are removed when the wound is healed. Range of motion, ROM, exercise is encouraged as soon as the wounds are stable to prevent stiffness of the ankle, usually at around 2 to 3 weeks postoperatively. X-rays are taken periodically to assess for union. Weight-bearing progression is allowed once the fracture is healed. Patients with extra-articular injuries treated with an intramedullary device may be able to weight bear as early as 2 to 3 weeks. Partial articular injuries treated with plate fixation are highly variable in severity and may be able to advance weight bearing at any time from 6 to 12 weeks depending on the specific injury. Weight bearing may not be possible prior to 12 weeks for fractures with severe comminution and for complete articular injuries.